bashing NP. I want to use it more, if you're watching this, more of what can we learn from this? How can we prevent this from happening? Whether you're an RN or whether you're an NP. Mr. Midwife may or may not be joining us. He's helping someone move. Caleb he was not able to join us. These are all panel members from Nurse Liz's channel. Make sure you check Nurse Liz out. But these are all panel members from her panel. And Caleb has written a pretty extensive list of what he does to prevent medication errors. So without further ado, Nurse Adrienne, if you could introduce yourself, just a little bit about you, let us know how we can connect with you, your socials.
Sure. Yeah, thanks. I'm Nurse Adrienne RN. I actually have my website up there. However, the best way to reach me, I'm a board certified patient advocate. That's what I do. I provide private patient advocacy to clients, patients, all across the board, all different diseases. I do clinical support, and I also do I've just recently added medical billing negotiation to my list of things, services. So you can reach me at either info@nurseadriennern.com, or you can just go to my website and hop on, schedule a call. And thank you so much. Thanks for letting me. It's nice doing this collab with you, Bridget. I just want to tell you I appreciate it. Thank you so much.
Thank you. I love having you on. And I just want to say too today, in a world of cancel culture, I'm going to be reading Caleb's, Mr. Midwife may be on, Nurse Adrienne may be on. We all come from differing backgrounds. We all may have different perspectives, and what they say today is, their opinion, their thoughts. And it doesn't always reflect what my thoughts are, but in this world, we should start to embrace more differences versus like trying to cancel people for having different opinions. We should hear different opinions. But let's add this article of the NP that was sued, and I will read you the facts of the case. Let me move it to the screen so that I'm looking at the camera. Okay. So the patient, Mrs. E, was in her late 60s and had various chronic conditions, including end-stage kidney disease, congestive heart failure, and obstructive sleep apnea. She developed a rash on her neck, and her regular primary care physician, whom she saw regularly for the treatment of her chronic issues, was on vacation, so she went to her local walk-in clinic for care. At the clinic, she was seen by Miss N, an NP, who examined the rash and diagnosed it as herpes zoster, also known as shingles. The patient was prescribed valacyclovir at the normal dosage for treating herpes zoster, 1,000 milligrams, 3 times per day. When prescribing the medication, Miss N failed to take into account the patient's kidney disease, which would have signaled the need for a lower dosage of valacyclovir. Mrs. E filled the prescription and began taking the medication. Within a few days of starting the medicine, she began to experience shaking and spastic movements in her legs. She called her regular physician's office and described the symptoms to a PA, who advised her to go to the hospital. At the hospital, Mrs. E was diagnosed with valacyclovir overdose and was admitted to the hospital. Nurse Adrienne, are you able to see the screen on your end?
Yeah, I can see it. Yes.
Do you want to read starting like over here over the next 3 days and then just?
Yeah, I'm going to pull it up over on my screen. Perfect. Where it's a little bit bigger.
I know it can be grainy.
For my old eyes. So this woman over the next 3 days, Mrs. E underwent dialysis to flush the medication from her system. Because she had some kidney problems, right? After the dialysis treatment, the shaking and jerky movements resolved. At the same time, the patient began experiencing difficulty breathing, and her vital signs became unstable. That means blood pressure, respirations, temperature. Mrs. E was intubated and placed on a ventilator in the intensive care unit, ICU, where she developed pneumonia. So that means that she had a tube in her mouth through her trachea down to help her breathe, mechanical breathing. When she improved, she was removed from the ventilator, because that's always the goal, and moved to a rehabilitation area of the hospital, which I'm assuming is an acute rehab. However, she didn't fare well. She required dialysis and became weak and hypotensive. She was transferred back to the ICU, where her respiratory status declined, unfortunately. And she again required intubation and mechanical ventilation. Her situation continued to worsen because of her compromised condition. She developed a blood clot in her leg that required surgery to insert a filter to prevent the clot from reaching her lungs. She required a tracheostomy and a feeding tube. Did you want me to continue?
Yeah, keep going. Well, I think I'll take like from the case, I'll read that.
Okay. So this is so as we can see, this is a very complicated case. It starts, a very complex medical journey is happening. The patient was then transferred to a long-term care facility where they tried unsuccessfully to wean her off the mechanical ventilation. Within a month, Mrs. E was found unresponsive in her room and rushed back to the hospital where she passed away.
The case. Mrs. E's widower sought the counsel of a plaintiff's attorney, and the attorney consulted with an expert physician to discuss whether the prescribed dose of valcyclovir fell below the standard of care and whether it was the proximate cause of patient's death. The physician was critical of Miss N's prescribing and believed that this had caused Mrs. E's death. So, well, let me keep going. The plaintiff's attorney then consulted with another medical expert to assess whether the hospital had provided proper care and treatment to the patient. The expert believed that the hospital had met the standard of care in treating the patient. The attorney suggested that they approach the NP's employer to explore a possible negotiated settlement. At the meeting, the defense attorney took the position that even if the NP had prescribed too much valcyclovir, the overdose caused only temporary injury. They felt that the NP was only responsible, if at all, for a few days worth of harm. So again, this is from their side, obviously. So they're playing devil's advocate, like, no, this was not the cause of it, but not the extensive hospitalization or death. The parties couldn't settle, and the plaintiff's attorney officially filed the suit. Discovery began and included the exchange of thousands of pages of medical records. Depositions of all parties and witnesses were completed. Expert reports were exchanged. The defense was eventually forced to admit that Miss N should have prescribed a much lower dose of the medication. However, they denied that this mistake caused serious injuries or death to the patient. After several dialysis sessions, the medication was flushed from the patient's system, argued the defense. Thus, the error only caused the temporary shaking and spastic movements. The patient's death, maintained the defense, was caused by her extensive pre-existing comorbidities, which would have prevented her from living a long life even if she had received the proper dose of valcyclovir. The plaintiffs were prepared to argue that the medication overdose was the inciting factor that set into motion the unfortunate cascade of events that ultimately led to the patient's death. And that's how I feel too. It's like, even if it wasn't the medication, it was a domino effect. So that's her prescribing set that cascade of events. After the court set a trial date, settlement negotiations began again, and this time with the assistance of a private mediator. At the mediation, just weeks before the trial was scheduled to start, the parties reached a confidential settlement to resolve the case. So, Nurse Adrienne, what are your thoughts on this case?
Well, I mean, I have a lot of experience with these kind of patients, and dialysis patients. Now, I'm assuming this patient was not a dialysis patient prior. It doesn't say.
It doesn't seem like it. That's kind of what I gathered too from that.
And we don't know other comorbidities. However, what I do know is that dialysis is extremely
end-stage kidney disease, congestive heart failure, and OSA, obstructive sleep apnea.
Oh, right. Okay. Yeah. Okay. Right. So she has. Thank you. So she has sleep apnea, right? So she has trouble breathing. When she sleeps, she may have also had atrial fibrillation as a result, which we don't know. She had congestive heart failure, which is an issue of fluid overload. That's one of the side effects. So she's already got some issues going on, some pretty serious issues at the, late 60s, I believe is what it says. So it's hard to say. I mean, for certain, there has to be caution in prescribing, and there has to be a good, solid clinical foundation of pharmacology and pathophysiology for anybody, anyone that's treating patients, especially in an urgent care, and to really make sure you take that time to assess those patients. However, that said, in my estimation, there could have been any number of things that happened to this patient that would have led to her requiring dialysis. We don't know, anything about the dialysis, the details of that. It's not uncommon for patients to become hypotensive if they're not managed properly in dialysis. And even if they are, it happens. We also know with ventilator, the pneumonia caused by ventilator, right? More than likely that the statistics there are very high mortality. The percentage of people on ventilators who get pneumonia is high. So there's components of responsibility that lie throughout the healthcare system. Is it, did this cause her to pass away? I'm going to say I don't believe so. I think that there has to be some other examinations, because you don't get ventilator, acquired pneumonia. I mean, that is a form of negligence in and of itself. So, I mean, that in and of itself is cause for some patients to bring action, legal action.
And there is a lot of medical negligence in the hospital for me, and that's again where we can, agree to disagree. Like for me, I'm trying to do two things at once. For me, I kind of take it's the prosecution, right? I take the prosecution stance of agreeing. And again, I'm not bashing the NP, but she made a mistake, prescribed too much medication that triggered this cascade of events. But yes, I think upon further examination, was there negligence? And, there's so much negligence at those SNFs. Like there's not enough staff. There's not enough nursing staff. It's just like one RN for 20, 30 patients. So she developed a blood clot, right? That's negligence, because you're not repositioning them every 2 hours. Immobility. Did she have SEDs on? So I don't, but again, she would have never been in that predicament had it not been for the NP prescribing what she prescribed.
Yeah. And I would say too, I mean, I was a floor nurse for 12 years, tons of renal patients, cardiac. We were kind of a one size fits all, trauma, neuro unit, strokes. I certainly, with any renal patient, as a first year nurse, would have questioned a traditional valcyclovir order for any renal patient. And if the doctor or the prescribing provider didn't want to, listen, then I would consult with the nephrologist and let them know, hey, by the way, just so you know, the providers prescribed this medication. You may want to talk to them before I administer it. What do you think? Right? Because valcyclovir is and also, we don't know, was it actually shingles? Again, part of the neck is a C3 dermatome, but that's not often where we see shingles.
It normally starts in the trunk. So it's like, we're not even going to, we don't even know, like, is that really
right?
Like, there's so many unknown factors.
Yeah. And just, so people know, typically shingles, if it's called this, there's different dermatomes, which correlate to different nerves. So on the neck, it is going to be on the side of the neck. You're not typically, and I'm not saying never happens, you are not going to exclusively see shingles like on the anterior or posterior of the neck. It is going to be mostly on the sides, and it could crawl up. And if it gets up to this area here, that is an emergency. But, we know that.
Just FYI, like if shingles ever is on your face, like it is a medical emergency because you could lose your eye. But normally it presents on the trunk here, and this is what it looks like. Just a little tidbit of knowledge.
Yeah, because I know in the hospital, and a dozen years in the hospital, there were several patients who had shingles, came in, and I can tell you, dermatology is not an area of expertise of any specialist other than a dermatologist. And often the primary care, the intensivist, or the not intensivist, the hospitalist, they really didn't know a lot of these basic, dermatological, issues, and really how to diagnose them. And they weren't really certain with confidence. Not to knock them, it just wasn't. I can't ever even recall a time when I felt that they were confident about what they were speaking about. And I would often, consult other doctors and say, hey, what do you think about this? Or some other nurses who may, have had that more experience treating those patients. It's not very clear cut, but certainly seeing it on the neck, it just makes me wonder. But for sure, we have to think about when you've got these drugs, when you have a renal patient, you have a kidney patient, or if you are somebody who has a compromised kidney function, whether it's from a prior disease process or a chronic disease. It is really important to lead with that with your providers, and also to educate yourself. And this is something where you have to have the creatinine clearance. You have to know what that is. That's not something that's going to be tested at a urgent care, I don't think.
Correct. So I have worked at a retail, like a urgent care, right? And this is a condition that we do treat. So what can we learn from this? Always get a thorough past medical history on your patients. If you're a person not in healthcare, everyone's a patient essentially, right? Even if you are in healthcare. But so if you are a patient, what can you do? We really need to know your past medical history. It is relevant, even if you think it may not be relevant, because medication is metabolized. Is it metabolized by the kidneys? Is it metabolized by the liver? So please, if you're a nurse practitioner or whoever, I don't really get like medical doctors usually watching this channel, but if you're in healthcare, period, MD, NP, DO, whoever, PA, you need to get that thorough past medical history. And having worked in urgent care, I know, especially where I worked, like initially, we didn't have help. I didn't have an RN helping me initially. It was me doing everything, the check-in process, insurance verification, like in 15 minutes. What a nightmare. I'm working telemedicine now and I get 15 minutes. I meant 15 minutes. Like I get 15 minutes. Sometimes we're live. We don't even know what we're saying. But I get 15 minutes now to see my patient in telemedicine, and I love it because I'm not doing all the extra stuff, right? It's just face-to-face time, 15 minutes. But before I was expected to do a plethora of things in 15 minutes. So I know that the time is unrealistic, the time slot, but it's your license and someone else's life on the line. So unfortunately, you're going to have to slow down, and you may be behind, but that's preferable to you harming someone else. So you may need to ask your patient like yes or no questions to get more answers. Like, do you have any? And then the other thing I would say is anytime you're prescribing a medication, think about how is this medication metabolized? In the case of valcyclovir, through the kidneys, right? Like, yes, liver, kidneys, but primarily kidneys is very nephrotoxic. So what other medications are they on? Are there any drug interactions? You don't have to know it all yourself. Use your resources. There's UpToDate, there's Medscape, there's Hippocrates. I know UpToDate is very pricey, but it may be worth it, right? Especially if you get CME money. So ask them, do you have any kidney issues? Do you have it? Like, sometimes they will tell you, and I'm sure you've encountered this, Nurse Adrienne, like they will check no past medical history, but they're on metformin, they're on lisinopril, they're on hydrochlorothiazide. Does that happen to you?
Oh, yeah. I mean, certainly, again, I was in a hospital environment. So I would say, but now as a patient advocate, part of what I do is make sure that my clients have a full inventory of all of their active medications, everything. So there's a couple distinctions here. There's what your providers have prescribed to you. There's what you actually take. And then there's all the other stuff people take, the supplements or maybe some other things that they might take. So those are not all the same list. And some, so it's really important to take that time. And unfortunately, in urgent care situations and even primary care, 15 minutes, even not long enough. I mean, as a nurse in the hospital, I had 12 hours with my patients. I would often, because our system would interface with the public, the community pharmacies, I was able to reconcile things and actually double check or, make some phone calls if I needed to. And also knowing the patient, if they're telling me, or I'm looking at them and I'm thinking, wow, they're super puffy around their eyes, they're wheezing, they're tripoding, whatever it may be. They probably have a history of CHF, some renal problems. They're probably on Lasix. They're probably, on some cardiac meds. And then I look and see who are their doctors, right? And then that also paints a picture. But in what I do now, I'm able to facilitate and educate patients to understand the importance of being really concrete and factual. But I would say, I'm just curious, like for you, would you have gone with the lowest minimum dose of 500 milligram once a day? Like, what do you think you would have done in that situation? What would be the best thing?
So, like Adrian had mentioned, ideally this would be being prescribed at a primary care office where you have labs on the patient and you know their creatinine clearance or their GFR, right? But if I tend to be very cautious as a prescriber, so that's just my approach. I'm very conservative. Maybe other providers are okay with being more aggressive, but me, I always just err on the side of safety. And I will go lower when reasonable, right? Not always, because you need a therapeutic dose for like antibiotics and things of that sort. But for example, I'll give you an example. Like, I will not prescribe really broad spectrum antibiotics if I know that that's not first, like the guidelines don't indicate that, right? So how do I know all of this? Well, one of the things too is like, make sure you go to a good school. Make sure you don't go to a diploma mill. And that's another thing. Like, when you're studying in school, you're studying and you have people's lives in your hands. So you're not just studying for a test. Make sure you know your material. But additionally, I had a great pharmacology teacher. So shout out to, I believe he has a doctorate, Dr. Blackwell. He's an NP, great teacher. But also, like, there's resources like Up to Date. This is Medscape. Up to Date, again, pricey, but Medscape free. Hippocrates, I had logged in, is not as expensive as Up to Date, but you have guideline. Up to Date is better in regards to like having like, what is the guidelines, whatever. But it will show you like, this is the dosage for a normal person, like with herpes zoster, 1 gram PO every 8 hours for 7 days. So 1 gram is the same as 1,000 milligrams. And then here are the dosing modifications for like genital herpes or oral, like HSV1, shingles, herpes zoster, shingles, genital herpes. And then it shows like their creatinine clearance. So I would, if this person in this situation, they said that they had end stage kidney disease, I honestly, and again, who knows if she disclosed that, right? Who knows if she disclosed that she was in end stage kidney disease? But I would have opted either like having her like calling her primary or care and saying like, what is at least getting some information, like, hey, do we have her creatinine clearance available, or what can the provider are they comfortable prescribing it for you through their emergency line? But if absolutely necessary, I would have gone with the lowest dose. Just Lori's joined us, just as a precaution. Hi, Lori.
Hi.
So this is Lori. Lori, go ahead and introduce yourself.
Hi, everyone. I'm Lori Brown. I'm a registered nurse as well as an attorney, and I have two parts to my practice. The first is doing professional licensing defense, so I'm particularly interested in this issue. And then I also help nurses start and grow businesses.
Thank you so much for joining us today.
Thank you. My websites are yournurseattorney.com and empowerednurses.org, empowered past tense. Thanks for having me.
Thank you. So yeah, I did have a case where a patient came in with shingles, and I opted to go for a lower dose. It was therapeutic for him, because that's always a concern too. Like, we want to make sure that we're not prescribing something so low where it's not working. But he didn't have end stage, I again, when your hands are kind of tied, you can always also ask the pharmacist, like, hey, what are your thoughts on this? Like, use your resources if they are available to you. Mr. Midwife, hi.
Hi, how are you?
Good, thank you. So Lori, did you have a chance to look over this case, and what are your thoughts?
I briefly reviewed it. I do think it's so important how that nurse practitioners review meds and labs. I had a case with a nurse who was, should I share it?
Sure.
It's a professional.
It's as long as you feel like it's okay to share in regards to like privacy and everything,
Yeah, I'm not going to say any names or locations or states or anything. But she, a patient had, she kept recommending labs, and the patient said, I don't have insurance, I can't afford it. Well, apparently the patient was getting care from a couple of different treaters, and nobody did the labs, and he wound up in ICU and DKA. And
Oh, wow.
the problem was lack of documentation. She didn't document that she had recommended the labs, and they refused. And you're going to live and die by your documentation every time.
And I wonder if in this situation, the patient disclosed her past medical history, because in my experience, a lot of times they just want to go to the clinic. They want that prescription. They don't disclose. Let me see if I can. Yeah, there we go. They don't disclose their past medical history because they just want to be in and out. And they know if they disclose too much, then, it's going to be more questions. And sometimes it's like pulling teeth to get a past medical history. But I tell them, like, listen, this is for your safety. This is to make sure that we are prescribing you, that what we're prescribing you is safe. And I wonder if in this situation, maybe they didn't disclose it. And if the nurse practitioner had types like patient denied, right? Like denies past medical history, denies taking any medication. Who knows if she didn't even disclose what meds she was on, if there were other nephrotoxic meds that she was taking.
It's also important to get previous medical records as well.
But that's not we don't have labs, and we don't have a previous medical record. We don't have that luxury when we're working in like an urgent care setting.
Right.
We have to rely on what we're told by the patient.
Yeah, I'm going to put a link here in the chat, and I'll put it in the comments. You guys can feel free to share this. There's a campaign called Take Charge. It's a very important campaign. Everybody should take a look at this. It's basically 5 steps to take charge of your healthcare. And part of it is creating your healthcare proxy, a medication list, a concrete medical history, asking caregivers to wash their hands. It's pretty simple. We're in step 3 right now of the Take Charge campaign. And this is part of a nonprofit I'm involved with, Pulse, but this is a dedicated website. And this is actually a campaign that is used by hundreds and hundreds, actually, of hospitals. It's on the Joint Commission's website. It was created by the person who started Pulse, Patient Safety Education and Advocacy. And so please, everybody, if you're watching this, create your own medical history. Put it on a spreadsheet. Have a document. Have it taped to your refrigerator. Make sure that you have it. I mean, I would like to believe that this person, because they have an extensive health history, that they, were transparent. But you also kind of wonder, let's just talk in general about shingles, right? So one, you'd hope that person would have had their shingles vaccine. So please also look into that if you're age appropriate, or may have already had a history of shingles. I mean, it's not that it's impossible. Shingles can show up at any time. But that's also another reason to check with the pharmacy, because had this person already had valcyclovir prescribed, or did they even understand, you also don't know what is their own comprehension of their health status, right? Who was with them? So make sure that you have that medication list and your history really fully available, not a big, long story, just bullet points. And that helps these practitioners so much.
I think, so Shakira said, sometimes calling the pharmacy to get a reconciliation can inform some medical history, but in urgent care that may not always be possible. Always best to get records, labs. Yes. Another thing is maybe asking them, have you had recent labs? Can you pull them up on your phone? That could be something. Again, I know that's time consuming, but it's worth it if they have that available. And at the end of the day, if you don't feel comfortable prescribing something based on their high acuity, based on their past medical history, they may get upset, they may get mad, but that's perfectly acceptable to say, you require a higher level of care that I'm not able to provide here based on your past medical history. And unfortunately, I cannot, I won't be able to treat you.
Mm-hmm.
And, sometimes I don't want to put blame on anybody, but sometimes patients lack understanding of their self. You'll ask them. I'll ask patients, any problem with blood pressure? No, I don't have high blood pressure or anything else. Okay. Then later on in the interview, you're saying, well, what medications do you take? Well, I take labetalol. But you said you didn't have any problem with blood pressure. Well, I don't, because I take the medication. So they lack that. They don't connect the dots. It's right
Yes.
up there with, I had a patient one time tell me I'm allergic to glyburide. Okay, what does glyburide do? It drops my blood sugar. That's so they don't connect dots in the same way. So this practitioner may have asked her, any problem with your heart, lungs, kidneys? Nope, none of that.
Yes.
The patient totally blew off the fact that she's on a medication or that she does dialyze or anything else like that. So
I
So
also want to just add one little tidbit here, that if it's shingles and she called the primary office, the primary's on vacation, I get the person answering the phone is not a healthcare professional necessarily, but shingles is contagious. It is airborne percussion and or contact, depending on if the lesions have dried. So, there's also that aspect that's a little irresponsible of the primary physician's office, to, not notify or let the patient know if it could be, or to really do some follow-up. So, again, it's just, there's so many points we can complete the circle better on educating patients and giving them the proper referrals.
So Shakira has a question for Lori. So Lori, what do you think about Shakira's question?
If
the patient filled out an intake form and did not check the box for a chronic condition like CKD, would that provide some protection?
It would, but you should also ask yourself and confirm. Patient denies any history of chronic conditions.
Okay. And Mr. Midwife, that's exactly what we were talking about before you joined us, is that I sometimes will ask and they'll say the exact same thing. No, I don't have any past medical history, but you look at their list and it's a laundry list. It's metformin, it's lisinopril, it's hydrochlorothiazide. So if you're a patient watching this, just because you take blood pressure medication does not mean you no longer have high blood pressure. That is helping control it. You still have that underlying diagnosis. Same thing with like metformin. Like just because you are taking diabetes medication doesn't mean you don't have diabetes. You have these conditions. Your medication is help keeping it under control. If you were to stop that medication, your blood pressure would rebound. You would have high blood pressure again. If you are taking a statin, unless again it's like preventative because you have diabetes or other comorbidities and your doctor's being conservative in your treatment. But if you're taking a statin like a atorvastatin, rosuvastatin, you have high cholesterol. Just because you take a statin and your cholesterol levels are now within normal, like you still have high cholesterol. The statin is doing its job. There's
just like with any disease, anytime you diagnose with a disease, you own that disease, you keep that disease the rest of your life. We can control it, we can minimize the symptoms, but you always have that disease and you will always carry that disease.
Thank you. Anything that, or let's shift. I did want to share because Caleb took the time to write a pretty lengthy response to how, and I thought it was, so again, this is Caleb's, what he does. This is not me saying this, but I actually think he makes some excellent points here, and some great interventions, and it just goes to show everything that nurses do behind the scenes that patients, don't realize that we're doing. And this is why I'm so passionate about proper staffing and working to the top of our license when you're an RN, because when you make RNs do a lot of the stuff that could be delegated, like changing patients, ambulating to the bathroom, things of that nature, you're taking away our time to critically think, to make sure that we are analyzing and being that safety net for patients. So Caleb says, working agency, I commonly carry 200 plus patients' generic chronic issues in my head. I try to make mental note of amiodarone, antiarrhythmic meds, and or any uncommon cardiac medications because they often have less than pleasant medication interactions. There are common antibiotics, Bactrim, fluoroquinolones, and common meds, gabapentin, acyclovir, etc., which acyclovir is in the same drug class as the valacyclovir. That I double check BMPs, BUN, creatinine, GFR, while still on the phone with on-call MD because of renal clearance issues. Any fluoroquinolones get a double check against SSRIs because they don't place nice with so many meds. And what he means is like there's a lot of drug-drug interactions. If a patient is on dialysis, I always make specific note to the on-call MD of, because I think he works nights. That's why he's saying on-call, of that with daytime. Wait, I lost my place. Daytime of dialysis, because it makes major difference in the timing order of so many medications. I also try to make note of the on-call MD of any diabetic, especially those on insulin, due to increased risk for renal clearance concerns and or blood sugar concerns related to corticosteroids. So corticosteroids can raise blood sugar levels. So if you have a diabetic that's on corticosteroids, you would anticipate that they would need more insulin in the meantime. If a patient is on anticoagulants, especially warfarin, I note that to the MD and often suggest an increase in PTI in our schedule. If I get an unusual order, high dosage, low dosage, high frequency, low frequency, long duration, short duration, etc., I question the order and ask for the reason for the abnormal factors. So, I mean, you can see all of the checks he's doing. If there's something unusual, like multiple anticoagulants, NSAIDs, unusual insulin regimens, new benzos, multiple CNS depressants, etc., I try to make note of them when calling in admission orders. NSAIDs get extra special note made, especially when combined with rich GI history and or anticoagulants due to dealing with geriatric population. And not only do NSAIDs increase your risk of GI bleeds or ulcers, but also they are metabolized. They can raise blood pressure because they affect the kidneys. So that's, you know, he also goes on to say that he uses resources, Medline, drugs.com. But what do you guys do in your professional life to help prevent medication errors or make sure that you're prescribing correct dosages?
So I mostly just I take as thorough a history as I can. I do exactly what I had suggested earlier. I go through any problems with your heart, lungs, kidneys, diabetes, high blood pressure. Go through this laundry list, and then I go through their meds and compare their meds with what they just responded to as far as yes and no answers. And I try to reconcile that. And if there's any discrepancy, I say, okay, you just said you don't have high blood pressure. What's the lisinopril for? Oh yeah. And so I try to go down that. It's impossible to catch them all. It really is. But you can catch the ones you can. And if there's any question on my mind, I hunt down one of the doctors and I find out, you know, am I on the right path here? Do I need to change something? And quite often I'm on the right path, but sometimes they catch something that I missed. So
I think another piece of advice that I would give is stay humble in your profession. Don't think that you have all the answers. Always learn. Always have a learning mindset that you're still learning, that you can still learn more. Double check, use your resources, because the moment you think you know everything, that's where you'll make a mistake. You'll be arrogant. You'll overlook something. I still to this day will triple check things before I send them. Did I make sure that I ask all the questions? Did I rule out this? Adrian, what were you going to say?
Oh, I mean, it's been a few years since I've been clinical at the bedside, but I would just say Caleb's list is fabulous. We should just, make a PDF of that and some kind of document and share that. I mean, it's just those like instant things that, you get hardwired with as a nurse and that are really important. And I don't know if it depends on if it's about where you go to school or what your initial training is. I mean, I just was trained to be very rigorous in the pathophys and the pharmacology. And, I'm not a prescriber, I'm not a provider. But of course, I worked with a lot of brand new hospitalists and, we like to say we trained a lot of doctors. And so, of course, it's that, was it, I don't know what show it is, the scene where, the nurse comes up to the doctor and is like, did you want me to give that 5,000 milligrams of morphine to the patient and kill them? Or did you want to try and prescribe something else? Right. And there was a lot of those kind of conversations. Hydralazine, I had a doctor prescribe, I think it was a total of 500 or 1,000 milligrams of hydralazine. I mean, it was just this crazy high dose, right, of throughout the day. And I had to call and say, hey, I don't think we're going to give this. Do you want to rethink this? So just also understand that nurses are often in the hospital setting, there are medication prescribing errors that do happen, and often because of poor staffing, because same thing, we're doing all these other tasks, right? There isn't the time to really be looking at something, or you might be on a break and somebody else is giving the meds and they're just going to see the order and hand the med out, right? They're not going to do all that work. So it is really important that, in healthcare, that nurses have enough time to do that kind of critical thinking, that the physicians have, the providers have the time, and that there's enough pharmacists on staff and pharmacy techs, because pharmacists, they were my best friend in that arena, in the acute side. I think that I just think, in the legal aspect of this case study is, on the, again, I just see that there's so many pain points throughout the whole story, right? Starting with the valcyclovir, and also the fact that patients do make it like Where's Waldo to figure out their medical history and meds. I don't know why it is so hard, because you could ask somebody a myriad of other questions and they could list, the name of all the dogs they had for the last 50 years. No problem. But you ask somebody their medication list and it's like, well, I got a green pill, I got a red pill, I got an orange pill, I got this. And I mean, I would literally sit with my patients with a pill finder app. Like, did it look like this? Was it scored? Did it have a mark? What's the mark? Till we drilled down. And then at least, okay, now I've kind of got an idea. Now let's, do a double check. So for the patients out there, don't make it a game. This is your life. This is your life. And if you have a nephrologist, you have a specialist who's treating something, please always have that information with you, so that if you are in urgent care in an ER, you can contact that person. The provider can contact that person. I mean, it is really important, because a lot of times, in that fast-paced setting of urgent care, ERs, those calls are not always going to be made unless the patient is then admitted. But if they're not being admitted, it often is not going to be made. And so it's very important to let your providers know when you're having some kind of medical issue.
And
I would
yes,
also, oh,
that is the motto that was drilled into us, especially like with older adults. And there's like a criteria. Is the medication on the Beers list, right? And those are medications that you should avoid in the elderly, BEERS. But yeah, the motto is you start low and go slow.
And
in the case of shingles, I mean, it's not an urgent issue, so you're not going to knock it out overnight anyways. Yeah, you want to have that loading dose, typically if it's a first time. But for shingles, I mean, it's not, whether it's a 500 you started with or some other low dose, it's not going to make a huge difference. You know what I'm saying? Or if it's something so urgent, then you have to send that person to an ER. Right.
Yeah, I mean, and with her history of like she's not filtering, like she's not clearing anything out. That medication is staying in her body. Like she has heart failure, she has end stage kidney disease. Like that should have been a dead giveaway that she needed a reduction in dosage. And if anything, I mean, was she retaining fluid, right? If they have edema in their extremities and they're telling me they don't have anything going on with them, well, I noticed that your extremities are swollen. Can you tell me more about that? Caleb also had said, what advice would you give to patients is have a medication, and this is kind of what you covered, Nurse Adrienne, but have a medication list with everything that you take both regularly and an as needed basis. This includes how much, how often, what route do you take it, alcohol consumption, illicit drugs. I'll give you an example. For patients that are taking erectile dysfunction medications, there's certain illicit drugs like cocaine that could be deadly, right? If you mix Viagra with cocaine, or if nitrates and Viagra are also deadly. So it's very important that you disclose everything that you're taking, even if you don't think it's relevant. We're not judging you. We just need to know what you're on. Any non-substances, smoking, vaping, poppers, again, poppers contraindicated with Viagra, any buccally absorbed substance, dip, what's your diet like? So he goes, grapefruit juice. There's a lot of interaction with medications and grapefruit juice. Dietary issues, he goes on and on and on basically, but realize that the medications you receive inpatient may look very different from what you take at home because the pharmacy you use at home. Okay, so that's just, I think here he's referring to sometimes when we're in the hospital, patients will say, well, my pill at home is blue and here it's white. Well, it could still be the same medication. It's just a different manufacturer, a different laboratory is making it. But in general, I would say, and this is where having an advocate comes in, is it is always a good idea. Ask, what are you giving me? What is this for? What's the dosage? And is that something that you do, Nurse Adrienne, in like with regards to your patient advocacy?
Yeah, so I just put it in the comments or in the chat. So one thing that's really important is to write down who prescribed that medication so that if you need to do some follow-up, you can, and make sure, because oftentimes there could be, polypharmacy we know is an issue, and there could be the same drugs being prescribed to patients. It could be a combo drug that's in the outpatient side, that on the inpatient side, we don't have combo drugs for the most part. So the patient could be taking one component of that combo drug in addition to the combo drug and not know it because they don't know what's in the combo drug. And that goes for a lot of cardiac meds. And so it's also important to write down who prescribed the medication and why do you believe as a patient you are taking this medication. That's also very important because that creates an opportunity for education. Because oftentimes patients will say, well, I don't know, I'm on these 5 medications for my heart. Well, do you know what each of those are doing? Do you actually know why and what the purpose is and what happens if you miss that pill? Or what if you take this one at a different time than you should? Or, whatever that might be, because it's very important to be able to assess the patient's knowledge and where they're at. And so but that again is part of my concierge service. I mean, this process is like a 4 to 5 hour intake. It includes advanced directives. It includes, all the healthcare proxy, everything. Because in the state I'm in, I can write out somebody's advanced directive for them. So I can actually prepare that document. So again, I would say the medication list, medication history is just so important. And then for me, I also contact the providers and confirm. I confirm with pharmacy. I have access to the patient, my client's portals. So it's a real total kind of service, and then try to integrate everything and make sure that all the providers know I get that medication list to every provider to make sure that they know, because sure as heck, there's going to be 1 or 2 out there, if the patient's seeing 6 different doctors, that doesn't have a clue all the medications. So these are things that are very important. Make that medication list, send it to all of your providers, get it to them. Make sure that they have it. They can scan it in. They can enter it in their portal, whatever it may be. You don't even have to wait to see them to have the appointment. Just let them know, because there might be something that's a red flag. And we'll let the cardiologist and the nephrologist duke it out.
I would also add that if you're relying on those pop-ups to say about medication interactions, don't. You have to have this knowledge yourself. You cannot rely on a pop-up and use that as a defense. So you need to know your medications. You need to know the interactions. You need to ask about supplements as well, not just medications, because some supplements can interact with medications as well, the natural things that they're taking over the counter. So you can't just use as a defense, well, the pop-up didn't tell me that it could interact. That is not a defense. You need to know that these meds yourself. I love what the other person said about, having your nurse's drug handbook with you and your apps and whatever to look this stuff up yourself, and just don't rely on this technology, because it's not going to save you.
Yes, and review guidelines, review the latest evidence-based practice, what you should be following, cross-check drug interactions on multiple sites. Like there was a situation, again, for privacy, I don't want to disclose where I work or what, but we do have a safety net where we work, where if there is an interaction with that medication, it should tell us, right? However, one provider did post it so that they can make an update that, hey, look, this medication didn't flag, and it should have flagged. But because the provider she knew, even though it didn't flag, that's a contraindication to prescribe that specific medication with that medication. So you have people's lives in your hands. You have to take your job seriously. As patients age, their renal function declines. And my grandmother, she lived in Colombia. And again, this is getting back to a thorough past medical history. Basically, she had only one functional kidney. So you're already elderly. You have decreased renal function. Your patient only has one functioning kidney. Her renal function is her. It's going to be very low, right? She was going for an MRI. Yes, she was elderly, but she was stable. She was living life, right? She went for an MRI because she had a lump in her breast, got it removed, whatever, MRI, CAT scan. I can't remember which specific imaging study, but she has a little bit of that claustrophobia. So they gave her something for anxiety, right? And again, I'm here in the States, so I don't get all the details, but I just know for sure they gave her way too much medication because what they're saying is she had a cardiac arrest. Oh, but I know it was related to the medication. I know they gave her too much medication. They oversedated her, and she passed away. She was completely healthy. Yes, again, she was elderly, but she passed away. Similar to the Redonda, I think, it's a very similar to the Redonda Vought case where, she was given that paralytic agent. That lady passed away as well. But you have to know what you're giving, what dosage you're giving. Is it appropriate for the age of the patient? There's just many, many things to consider.
I think it's a
earlier.
Go ahead, Chad.
Caleb probably has a love-hate relationship with most of his providers. If he's waking them up at 2:00 in the morning and grilling them about, are you sure you're right? Are you sure you're wrong? Are you sure you don't want to look under this stone too? And in my practice,
Caleb, I don't think he cares.
Right. I don't think he does either. But I'd have nurses call me at 2:00 in the morning and wonder about this or that. And there's certain providers out there that, are you questioning my authority? Are you questioning my decision? That's the wrong mindset. Nurses are there to help you. Nurses are there to protect you. As a provider, they'll catch things if you let them. And so even if it's 2:00 in the morning, if with one eye open, you can try to understand what they're saying and at least consider it. Maybe they are wrong, but it's entirely possible that maybe they are right, and maybe they've caught something and are about to save your hind end as a provider. So there's that. And then part of the problem with the American healthcare system is we don't always interact and talk with each other. Nephrology doesn't talk to cardio. Cardio doesn't talk to obstetrics. ER doesn't talk to ICU. Nobody interacts very well. And those pop-ups that you do get on the computer are helpful. They will catch some things, not everything, but some things. And so it's hard to know. And patients are like witnesses at a crime scene. That little bitty detail, I didn't think it meant anything. Well, it does, but they don't know that, so they're not going to mention it. And it's difficult. It can be really difficult to ferret some of that stuff out. So it's very complex, very convoluted.
Mm-hmm.
I
want to ask Lori. Oh, go ahead, Bridget.
Well, no, just kind of tagging off of what Mr. Midwife said. I remember when I was working bedside and I was going back and forth between these two specialists, like he said this and he said that. And then finally I was like, you know what? You two just need to call each other because no, I'm not here to play telephone all day. I have other things to do.
Right.
Go ahead, Nurse Adrian.
So how did it end with the nephrologist and the cardiologist?
It never ends. It never ends because they have. Well, the problem is they're picking up two ends of the same stick. Right. They both have good patient outcomes in mind, but one's approaching it from, well, she's got a cardiac disease, yeah, but we can't give her these medications because it'll affect her kidneys, and it's this balancing act that everybody has to do. Ultimately, somebody wins, somebody loses, but it's two ends of the same stick, and it never ends well. It never ends like the other person's thought it should.
Yeah, nephrologists don't get enough credit. I was just, I want to hear Lori's opinion just about kind of backing up about the other components of this, the series of events that happened as far as culpability, responsibility with ventilator-associated pneumonias and all these other components, the woman came in, and because of this valcyclovir overdose, that necessitated all these different treatments. However, to find, that the nurse practitioner, the causation of death, right, or the settlement, because it didn't go to trial, right? But what are your thoughts as far as like, would this be more a situation where you would think of like a kind of a percentage layout of a settlement of, because you've got long-term care, you've obviously got something avoidable, VAP, you've got, all kinds of other issues, could be the, dialysis. I often dealt with dialysis mismanagement and issues, just because they were working 24 hours straight, or just, things were not just, there wasn't a totality of the picture clinically being looked at with the patient. So I just wanted to hear your insider opinions on that. Thanks.
So each state is different in terms of what, if there's, most states have what's called joint and several liability, which means that a person's individually responsible as well as in the group responsible. And what that means is that if there is a verdict against all of them, then they have to figure out how to divide it up. Now, the percentage of liability, that comes with comparative fault, and it depends if you're in a comparative fault state as to what percentage of liability that they are going to give each of the actors in the case. However, in one of the states that I'm licensed in, the way that it works is that the first tortfeasor, the first person who does the wrong action, and in this case, the one who prescribed, set into cause the rest of the chain of events. And it wouldn't have happened but for her. So in the one state in which I'm licensed, it's the initial tortfeasor who's responsible for all the subsequent torts. So it just depends on what state you're in as to how they divide it up, and if percentage of fault. In at least in one of the states that I work, the initial tortfeasor is responsible. The other tortfeasors can be responsible too with part of that joint and several, but they don't assign fault percentages.
Gotcha. Thank you. Always appreciate your opinion. I was also thinking about arbitration agreements, that often, you go to the doctor, you go to the provider's office, and even on the portals, right, you're signing it in order to make the appointment. You're agreeing to arbitration, which is a little shady. And then if you don't agree, you can't make the appointment. Again, a little shady. And I'm, California, you can't force arbitration on patients. But, how is this? What are your thoughts about the arbitration, these agreements, and can they be overridden in certain instances?
I am not an advocate for arbitration agreements. I think it waives our right to trial by jury. And there was a huge case against Google. Actually, it was like a sit out or a workout, whatever they call it, because there was this one manager at Google who was sexually harassing the employees, and several women brought suits against him, but through arbitration, it's all confidential. So nobody else knew about it, and nobody did anything about it. And I think that the whole idea of having trial by jury is for public, for the public to know. And had these suits been public, then this man would have been discharged a long time ago. So they had a sit out saying, we're not signing these employment arbitration agreements anymore. And they were actually successful. It was a huge win.
Yeah. I mean, I'm a certified mediator and arbitrator, and I think I think they're horrible if that's the starting place. I think there's a place for arbitration and mediation, but as far as the public record and precedent setting, at least if you're able to sue and later settle, which we all know trials are kind of, I don't know what the percentages are. I read that like something like only 15% of cases go to trial or something. So even if it's going to settle out of, is it less than that?
5%.
And it's 5. Okay. I had read that too.
Unfortunately, or fortunately, the vast majority of settlements are in favor of the healthcare provider, because the jurors are afraid that they won't get care if they hold a healthcare professional accountable, or like a small community hospital. They're afraid.
Right. Interesting. And so interesting also because like when you think about that conversion to criminal, like this case could have gone criminal. It could have been, oh, well, I have a DA running for office, so let's, prosecute this nurse practitioner because that's the end thing to do. That's what all the cool kids are doing. And, it's really, this is, I think, also why, because so many times they settle outside of court and, there's this, kind of new arena to get publicity because nobody's really, unless it's a murder or something, nobody's really caring what a DA does. So anyways, I thought that was interesting, and I thought about it in this case, like, would this person have been brought up on criminal charges? Because if you're saying you caused somebody's death, I mean, that's, I kind of wonder where's that fine line.
Mhm.
And if it can be that simple, then where no matter what else happened down the stream from that event of the valcyclovir in this instance, then, now am I going to be up for like manslaughter?
Mhm.
Well, and as speaking from a provider's point of view, and Bridget knows this as well, very few of us, I don't think any of us, but there's got to be one or two who go into this saying, none of us go into this saying, I'm going to hurt somebody today. None of us go into this to saying, I'm going to cause harm. And as a provider, I guarantee you, I do the very best I can with every patient, every day, with everything I do. If I make a mistake, it's a legitimate, honest mistake. And for that, I apologize. But I do the very best I can. Sometimes I don't have the information. Sometimes I simply don't have the information. And so I make the best choice I can given the circumstances. Sometimes because I do that, that doesn't end well. But I've done the best I could given the circumstances. And so to be always on the lookout for the next problem. If you're looking for problems, you'll find it. If you're looking for a lawsuit, you'll find one. They're out there. But just know that doctors, physician assistants, midwives, nurse practitioners, we all do everything we can, the best we can with the information we have for our patients. And so when we make a mistake, look at the totality of the circumstances. Maybe we just didn't know. Maybe it's something you didn't tell me that I should have known, which might have changed the situation, but it didn't. So
And that was one of the
go easy,
reasons
go
why
easy on us. Go
yeah,
easy on
yes.
us.
And like you said, the majority of us are going into it for the right reasons. And one of the reasons that motivated me to become a nurse practitioner versus staying bedside was, again, there's great physicians out there, great physicians. I don't, I'm not, but there were others that I said, I want a larger scope of practice so I can do better, right? So I can educate more, I can spend more time. That idealism that I have is I don't want to be like this provider. I want to be more like that, like this other good example. And I want to be able to prescribe and help. So we go into it for the right reasons, most of us. But, at the end of the day, I think our takeaway too is if you're a patient, please disclose everything that you are taking, whether you think it might be significant or not. It is significant. As a prescriber, like you have to know your meds. Always study, always do continuing education. There's pharmacology courses out there that you can take, Fitzgerald, Amelie, brush up on just, none of those are sponsored, but if they want to sponsor me, I welcome it. But always
Well,
brush up on things, have interaction checks. Yes, what were you going to say, Mr. Midway?
you would never ever send your 5-year-old into the pediatrician's office by himself. So why would you send your 95-year-old into the cardiologist's office by themselves or any place else? And the older you get and the more chronic conditions you have, you need to have somebody with you, be it Adrian or your daughter or your son or your husband, somebody else who can speak up and remind the doctor of things that you forgot to say. And when you get out of the, I encourage always to bring your husband, bring your wife, bring your whoever, because you're only going to remember half of what I say anyway. And there's going to be things that you forget to tell me. But if you bring somebody, they'll remember what I told you, and they can remind you to tell me the things that you had on your mind. And so bring somebody with you by all means. Absolutely.
And so those are any final points. I've said my piece. Lori and Nurse Adrian, any final points before we log off that you would like
One
to
more
leave with?
thing. Thank you. for you, who are worried about having a criminal matter filed against you if something happens, in Tennessee, it's a different statute. Usually, it's manslaughter. Like there's murder and then manslaughter 1 and 2, the unintentional. But in Tennessee, they have a third one, the completely unintentional. It's not like you get behind a wheel of a car driving drunk and kill somebody, because there was intention to get behind the wheel of a car and drive drunk. But so not all states have that. So don't worry about like the criminal matter for completely unintentional thing, unless you're in one of those states that has that law that you can get criminal prosecution.
And make sure you know what state you're in, right? So contact Lori and find out. I think as we have this really vast aging population in America, and there is a much larger group of people aging alone. I don't have kids. I don't have much family, just so to speak of. These are considerations. So this is why it's important to have a patient advocate and to have somebody who can come in remotely, like the services I do. I'm on FaceTime. I don't really go into the doctor's office with patients. But it's just as easy to go and FaceTime. So even if you can have a friend or you have a buddy, set up a buddy system if you can with a group of your senior friends, like, hey, we're going to cover each other and be with each other in these appointments because, who knows you best, but you're good friends, right? And it's like in the hospital I worked at, because I've had 7 or 8 anaphylactic reactions. My coworkers knew, like if they smelled somebody with perfume coming in, they knew where my EpiPens were. They knew like, hey, you better stay away from Adrian, get off this unit, go get a head cap, whatever it might have been. They were always on the lookout the minute I turned a little red. And this is prior to me going through menopause, which is why I'm red right now, having a hot flash. Thank you. So it's just make sure
I can help with that.
Thank you. I need that. I need that help. I'm ready.
We were talking about that, so she needs you.
I'm ready. Go to the takecharge.care website, check that out, go through those steps. It's all right there. This is just the first step, but make sure you see if you can get a buddy, some kind of buddy system in your community of somebody who's going to know when you're going to the doctor and that they can be there on call or just be an advocate for you. And that's what we train people at Pulse, Patient Safety Education and Advocacy. It's a nonprofit. We train community, just the average person to be an advocate for their family member or a friend. So we have a lot of resources on the website. Check it out. Thanks so much, Bridget, for doing this. And it's good to see all of you.
I think my uncle's visiting from Colombia, and he says that's my mom's side last name. So hi, if it is my uncle. If it's not, never mind. But thank you everyone for joining today. Shakira had asked, how do I stay abreast of medical knowledge? Aside from like Fitzgerald conferences, I attend office hours within my company just to learn from the MDs. I'm always reading. I subscribe to medical journals. Lori, any other ways that you recommend to always stay learning and abreast of the latest regulations, laws, medications?
I do send out a newsletter every week with tips and strategies to empower you as a nurse, or education about legal issues in nursing. So you can find that in it. Just sign up for any of my freebies at yournurseattorney.com, like what happens if I'm called before the board. That'll get you on my newsletter list and you'll get access to that.
All right. Thank you so much for watching, everyone.